Good morning. On behalf of those of us here at the Cooper Institute, we welcome you to Coffee with Cooper virtual series that focuses on taking control of your health and working towards a healthier future. This series presents up-to-date health and wellness information and offers suggestions for healthier living based on proven science. I'm Dr. Laura Defina, President and Chief Executive Officer of the Cooper Institute. For those of you who are not familiar with the Cooper Institute, Dr. Kenneth Cooper, affectionately known as the father of aerobics, established the Cooper Institute nonprofit in 1960 to promote lifelong health and wellness worldwide through research, education, and advocacy. By improving public health, the Cooper Institute helps people lead better, longer lives, now and well into the future. It is my pleasure today to welcome Dr. Eduardo Sanchez, Chief Medical Officer for Prevention for the American Heart Association, as well as a member of the Board of Trustees of the Cooper Institute. Dr. Sanchez is a principal investigator of the National Hypertension Control Initiative, as well as the American Heart Association clinical lead on Target BP, which is a joint blood pressure control initiative with the American Medical Association, and No Diabetes by Heart, a joint cardiovascular risk factor control initiative with the American Diabetes Association. Dr. Sanchez obtained his MD from the University of Texas Southwestern Medical School in Dallas, an MPH from the UT Health Science Center at Houston School of Public Health, and an MS in biomedical engineering from Duke University. In addition, he holds a BS in biomedical engineering and a BA in chemistry from Boston University. Dr. Sanchez is board certified in family medicine. February is American Heart Month, a time when our nation spotlights heart health and heart disease, the #1 killer of Americans. It is still the leading cause of death worldwide, according to the American Heart Association's Heart Disease and Stroke Statistics 2021 update. Today, Dr. Sanchez will be discussing the topic of Heart Month and how to improve your heart health and prevent heart disease. We will have a few minutes at the end for questions, so you can use the Q&A function in Zoom, and we've also received your pre-questions. We will get to as many questions as possible during this hour. And now it is my honor to introduce Dr. Eduardo Sanchez, who will begin by talking with us about Heart Month. Eduardo?
Hey, Laura, thank you so much for having me. It's really a pleasure. Ken Cooper is one of my heroes, mentors, like for so many others. And so it is a great privilege to be a part of this. And Laura, you and I have had the chance to work together now for a number of years. And the great thing is the American Heart Association and the Cooper Institute have, if you remember back from when we were in elementary school and learned about intersections and unions, we're not quite a union, but the intersection of Cooper Institute and the American Heart Association has a huge area in it where we have similar thoughts. Our mission is to be a relentless force for a world of longer, healthier lives. I think I heard you mention longer, healthier lives just a moment ago. And as you mentioned also, this is Heart Month. And the theme for Heart Month 2022 is recuperate your rhythm. It's actually reclaim your rhythm. And I'm saying recuperate because in Spanish it's recuperar su ritmo, but recuperate works better because Cooper's right in the middle of that theme. And the notion of recuperating, reclaiming your rhythm is that we all are yearning to get back to kind of the parts of our lives that we really enjoyed. I do want to be clear about that prior to COVID-19. And the focus of Reclaim Your Rhythm is in 5 areas. One is to try to reduce stress. But among the ways that we reduce stress are to add and or incorporate physical activity into our lives, eat healthier than maybe we are eating right now, perhaps because of COVID, and to sleep more at the very least. And in that de-stressing and the physical activity being done in a mindful way, sort of taking mindfulness to heart, maybe being physically active. You may just take a moment to center yourself, but physical activity is a really good way to de-stress. The second area of focus is actual physical activity itself. And we know from the great work done at the Cooper Institute, not only among adults, but among children, physical activity really does matter. It not only improves your cardiovascular health, but actually, as I stated a little while ago, improves your mental well-being. Eating healthfully, critically important. And the American Heart Association, like so many others, promotes a diet that includes probably more fruits and vegetables than most of us eat on any given day, includes whole grains, that is complex carbohydrates, more than the simple carbohydrates, and includes lean proteins. We as an organization are leaning more towards understanding and promoting the value of plant-based proteins as being a significant part of that makeup. And then the fourth area of focus is knowing your numbers around blood pressure. Hypertension, as you heard earlier, I'm involved in a couple of high blood pressure related programs through the American Heart Association, but high blood pressure is a public health emergency, I would say. 1 out of 3 adults in the United States has hypertension to a degree that they very, very likely ought to be on pharmacological agents, that is, they ought to be on medicine. About half of those people, even on medicine, do not have their blood pressure controlled. Why is that important? Well, high blood pressure is the #1 cause of stroke. It's among the #1 causes, among the high causes of heart attacks, sometimes called myocardial infarction by people who like to use complicated words to say heart attacks, and then also contributes to exacerbations, that is, episodes of heart failure in people who have it. So getting blood pressure under control is so important, and there's a whole lot of other things related. The fifth thing is doing a better job in our country of training people on hands-only CPR. There are pockets of our communities where hands-only CPR training has not penetrated. And the truth is that if you are trained, you can be that person who calls 911 and then starts doing chest compressions to the song Stayin' Alive, by the way, so that you do it at the right pace. And while somebody comes, you are keeping that heart going and keeping people alive. So Reclaim Your Rhythm is about the rhythm of CPR. It is about potentially the rhythm of moving your body, whether it's walking with your headphones or, quite frankly, as we've been talking this month, dancing in your kitchen while you prepare that healthy meal, which has, like, that's the trifecta: physical activity, healthy food. It's got to be good for your mind to do those things. So I'll stop there. I wanted to talk a little bit about what we're doing around Heart Health Month. And Laura, let's have a conversation.
So, Eduardo, those things are so critically important. And first with the CPR, just from a rhythm perspective, staying alive, what are you talking about there, just for our viewers who might not be familiar with that?
Oh, I wish I was so quick that I could get it on a search. But Stayin' Alive is a song from the movie Stayin' Alive. It's a Bee Gees song from back when I was young. And there are other songs that work that are at the same rhythm. But for people my age, Stayin' Alive is a Bee Gees song. Stop, Stayin' Alive, Stayin' Alive. And I'm doing the John Travolta move because it was a John Travolta movie. So Google it and you'll see, and then you'll see what you can find other songs that are going at the same beats per minute.
Excellent. And I really appreciate the dancing because that's exactly what I was looking for. Okay, so I'm really interested in this plant-based diet issue. Certainly, we all have to eat healthier, and we all know that during the COVID pandemic, there has been more poor choices made in eating. But the issue of whether plant-based diets are good for our heart, I think is really clear. But can plant-based diets reverse heart disease? There's been some literature out there about that.
That's right, Laura. There is some literature that would suggest that plant-based diets can reverse heart disease. I would say to you that the degree to which you have to be eating that way is a challenge, but it can be done. And there has been work that has demonstrated that reversal. But put a different way, eating a plant-based diet is going to move you towards more heart health. The evidence around that is very, very clear. And when we talk about plant-based diets, of course, more fruits and vegetables are part of that picture. I would add again, mixed carbohydrates. And maybe another way of talking about this is the less processed the food, the better, because that makes it more complete. And one of the things that we don't completely understand is that sometimes it's not just the nutrient, whether that's vitamin C or vitamin D, it's the packaging of the other things that brought you the vitamin D when you're eating a completely healthy diet. And we haven't unpacked all of those things that benefit us. But let me move to the other area where when sometimes we talk about plant-based diet, it's a little bit of new territory, and that's plant-based proteins. And we know that nuts and legumes is a fancy name for beans. And oh, by the way, just so that you can really seem real smart to people, peanuts are legumes, not nuts. Kind of nutty that it's called peanuts, but if you go look it up, peanuts are legumes. Legumes and nuts are really, really good for your heart. And the degree to which you can use beans and or nuts as in place of animal protein, not all the time necessarily, but at times, is the degree to which you start moving yourself towards that plant-based diet that when in the most adherent form can reverse heart disease.
Okay, so what I'm hearing is I don't have to just eat tofu to get my protein.
You do not have to just, so let's put it a different way. I like to accentuate the positive. Legumes and nuts are, in addition to soy-based protein substitutes, can help anybody who wants to eat a vegetarian or a vegan diet do so. Laura, I think I can speak for myself. I'm old enough to remember when a vegetarian diet was very, very limited in choices. But these days, vegetarian and vegan, there are so many choices out there, up to and including the plant-based meats, if that's the right word for it, sort of the meat substitutes, whether that's the burgers or the meatloaf. But you can also find really, really tasty recipes that are worth doing at home, because when you prepare it yourself, A, you're going to have to be physically active. Two, if you engage people in your family, you get that social connection, which is also so critically important. And you'll eat a healthy food that maybe if you prepare it, you'll have the satisfaction of having done it, and then you'll have the memory to do it some more every so often and get that benefit of a plant-based meal.
And so I think that is just such a fabulous point. You and I both grew up in generally the same generation where a lot of what we ate came in boxes and you had to open the container to take it out. And the one thing I love about cooking at home is we're teaching the next generation to eat plant-based diets, and we're modeling doing it at home. So I think that is absolutely a fabulous point. Okay, so let's talk about physical activity. I know what the physical activity guidelines say. They tell me I've got to exercise at least 150 minutes a week at a moderate to vigorous pace. If I want to perform better or lose weight, 300 minutes a week. But what if I just can't do that? Do I just decide to stay on my couch? How do you advise people?
Well, so there's a few things that we know for sure, and that is that a few things we know for sure. Some physical activity is better than no physical activity. Many of the things that we do every single day are physical activity. And if you did a little bit more, you did it with a little bit more intention, you might get a little bit more benefit out of it. What am I talking about? I'm talking about cleaning the house. I'm talking about making the bed. I'm talking about going up and down the stairs. I'm talking about going to the grocery store and carrying your groceries. That is physical activity. And the degree to which we do some is better than the degree to which we do none. A very interesting study came out just last week that seems to correlate physical inactivity with worse outcomes with COVID. So I'm not telling you that if you're physically active, that protects you from COVID, but if you're physically active, that might attenuate the severity that COVID might affect you as an individual. Another study that came out recently suggested that if every person in the United States did 10 minutes of physical activity more than they're doing right now, 111,000 lives would be saved. That is 111,000 less deaths per year. Let's put that in context. Strokes kill about 160,000 people a year. Diabetes kills about 110,000 people in 2020. We're talking about the number of people killed by diabetes could be mitigated, could be neutralized, if you will. Now realize it's not a life for a life. We're talking at a population level. But what it tells us is that the power of physical activity is tremendous. And to your question, Laura, 10 more minutes would have an impact on the population and would have an impact on people. I like to say, if you can do 5 minutes a day where you weren't doing anything yesterday, that's great. And for many of those folks, the 5 minutes will turn into 10 minutes, the 10 minutes will turn into 15 minutes. I will say, optimal benefit is going to come from that 75 of vigorous, 150 of moderate, or the thing in between that equals about the two. That's going to optimize your gain for the contribution and effort that you make. And you will feel that. And where I was going was not so much that, is that in this world, you have to set that time you have to set aside. It's one thing to, incorporate being more active into little pockets of your day, but that 30 minutes you're going to have to set aside. But, oh, by the way, Laura, you and I know this research as well. You don't have to do the 30 minutes all at once. If all you can do is 10, 10, and 10, or 15 and 15, you will get a huge, if not all of the benefit that you get from doing 30 minutes all at one time. So the recommendation is for optimizing the effort plus return. But the truth is, 10 minutes of physical activity is going to go a long way compared to being physically inactive. And I like to believe that once you get started, you're going to feel that and you'll want to do more if you can. And let's be clear, we're talking about physical activity. There are people who maybe can't move their bodies the way other people do. And I say facetiously, and I don't mean to say this disrespectfully, if all you can do is move a finger vigorously. The idea is if there are parts of your body that you can move, then finding the way to do that. And sometimes it takes working with an exercise specialist to find out what's going to work best for you and your circumstance. But physical activity is one of those protectors of our heart health, maybe better put, promoters of heart health. It improves our heart health.
So I think I read a great quote in the last week, which sort of it is exactly what you said, but all movement counts. And then I just want to, another thing that one of our friends, Ben Levine, likes to say is, you wouldn't not brush your teeth at the end of the day. And we really should be looking at physical activity as something that we must do for our preventive health care. So I think you're exactly right. Do what you can, 5 minutes, 10 minutes, get moving, because it does help protect the heart.
I think, Laura, there's one more thing, is that when it's possible, do it with others. There's the value of the physical activity. There's the value of engaging with another human being. And there is just the mental health aspect. You can have great conversations. I used to run with my wife, and I say used to because I was younger and my body would allow for it a little bit more than now. But we would run at such a pace that having a conversation was really nothing more than, it was guttural speech, because we would push ourselves. Now that we walk, even when we walk hard, we can have fantastic conversations. And so my wife and I will go out for a 30-minute walk, 45-minute walk, 1 hour walk. And it seems A, like less time, but B, you just accomplished a really nice conversation with somebody who you at least should be having conversations with, and you might very much enjoy doing so. So that's another thought about physical activity.
Okay, so 2 questions about physical activity. The first is, who needs to go see their doctor before they start a physical activity program?
So there's let's unpack that a little bit. One may be who needs to see their doctor. And so I am reminded now that Heart Month is also a time to remind people that there is very good reason to regularly check in with a physician, particularly if you're an adult. You know what? I'm going to change the particularly. In all phases of our life, a connection with clinical care is important. It's not that we all need to be on medicine. It's not that doctors need to rule our lives. It's that there's certain preventive services that can and should be provided. The obvious one for me, and I'm just putting it out there, is vaccinations. And we don't need to get too controversial, but vaccinations work pretty well. And the American Heart Association, because of the relationship between COVID and underlying medical conditions, the relationship between influenza and underlying medical conditions, including cardiovascular disease, is really, really a huge proponent of getting vaccinated according to the Advisory Committee on Immunization Practices recommendations. But then there's other kind of counseling that we know makes a difference, whether that's to quit smoking or never start, whether that's the degree to which one is involved in physical activity, healthy eating or not. And then there's certain tests that ought to get done with some regularity. Blood pressure checks probably ought to happen anytime you see a doc, because it's relatively easy to do. As I said earlier, it really is a public health emergency. And there's some blood work that ought to get done. Some of that is going to be specific to age and sex. So I'm putting that all in the context of the conversation about exercise should not be happening because you haven't seen a doctor in 10 years and you decide, I want to exercise, let me go talk to my doctor. It really might be, I just saw the doctor and we had the conversation, or I'm going to see the doctor and I want to put this in front of the doctor. I would say to you that the degree to which your physical activity is, walking at a like 15 to 20-minute pace, unless you have a fairly serious medical condition, in which case you ought to have a doctor anyway. I think that it's safe to start there. If what you're thinking about is training to run a 100-meter dash in 10 seconds, I would say, please ask yourself the question, why? But you might think about asking a physician about increasing intensity beyond what might just be either a leisurely jog or a walk. The other is if you're having any symptoms whatsoever, when you do regular activities, if you're feeling shortness of breath, or you're feeling compression in your chest, or you're having pains in your leg just from doing a little bit of physical activity, and if that's worse when you try to walk a little bit more than you do ordinarily, I think that's a warning sign to stop for a second and get in and talk to your doc. But I think, Laura, you and I would agree that conversation should have already been had. And you shouldn't be thinking, maybe I'm going to start being physically active today, and I haven't been for 10 years and I haven't seen a doctor for 15. So it's generally safe. It's always a good idea to connect with your doc. One more thing I've been telling people: if you had COVID and you took care of yourself at home, and there's many of us who did, call your doctor, let them know. Why? Because there are probably questions or thoughts about COVID and all things heart health. And I would say to you that we don't know. We really don't know, because COVID's only been around for a couple of years. And the only way that we're going to know is to model what was done at the Cooper Institute, which is have information about people so that when a decade from now or 5 years from now, we're trying to figure out how does this interrelate with experience with COVID, knowing that someone had it and the time frame when they had it will help us all better understand in 5 or 10 years what long COVID actually is.
Excellent. So I can't agree with you more about preventive healthcare and, you know, the 10 years since I've seen a doctor. One campaign that the government used to have was the Real Men Wear Gowns. Women and children tend to have a pattern of preventive healthcare. But for our audience, men don't always go to the doctor until they need to. But I would argue everybody needs to have preventive care.
I would agree with that. I would also say for men who don't want to wear gowns, you can go to the doctor's office and never ever have to put on a gown, because actually most of the things that from a cardiovascular health perspective and below a certain age, just involve a little bit of, and start with conversation. So, you know, it's like every first date. The gown is not the thing to be the first date thing. That might be the second date. There's so much to cover if you haven't seen a doctor in a while that, again, there are certain things that don't have to happen that first time. I'm being facetious, of course. You're absolutely right. Men seem to think that we are invincible. There are some interesting approaches that you know about. One of our now deceased colleagues, Ron Victor, did some really, really interesting work looking at using barbershops, particularly around how to reach African-American men who, like really all other men, are loath to connect with doctors. And yet for African-American men, much higher likelihood of having high blood pressure, higher than virtually any other race ethnicity group as a group of people, and no coverage. So seeing a doctor is important, but being creative about how to connect people is also critically important.
Okay, so let's focus on heart prevention. One of the questions—
Heart disease prevention.
Well, heart disease prevention, but when you go to the doctor, what tests should you be asking for? Does everybody need to get the expensive, extensive cholesterol testing that tells you size, shape, and function? Or, you know, what do we need to get versus what's nice to have?
So the American Heart Association talks about something called Life Simple 7. And earlier, before we started, I was feeling my lapel because I ordinarily have a pin with a 7 on it. I don't have it today, so I can't show you all. But Life Simple 7, I would say, constitutes the 7 things from cardiovascular health perspective that ought to be covered, addressed in any preventive visit. And in fact, those 7 things are covered in the 2019 AHA, ACC, AHA guideline on primary prevention of cardiovascular disease. So it lines up exactly with what you're saying. Those 7 things are not smoking. That should be addressed. Being physically active, we've talked about that. And at the very least, that ought to be asked. And Laura and I are of the school of thought that that ought to be prescribed as well. Doctors ought to be prescribing physical activity, just like we prescribe lots of other things. Healthy eating ought to be part of that conversation. And in an ideal world, and what we know is that connecting with dietary specialists, that would be nutritionists and dietitians, adds a wealth of value to what one physician might be able to do in one visit. The third or the fourth thing is healthy weight. And healthy weight is critically important. Whatever weight you're at, maintaining that weight and not increasing weight is a starting point, but achieving a healthy weight can be an end point. And healthy eating and physical activity are 2 ways to get there. Laura talked about physical activity. You're gonna have to do a little bit more than just enough to get your heart in great condition. The fifth thing is healthy blood pressure. We talked about measuring your blood pressure is relatively straightforward. Confirming blood pressure as high is a critical part of what constitutes the next steps. And then 6 is cholesterol. And it doesn't hurt to do at least one time, particularly at 40 or older, do a one-time check. Once you get it, if it's healthy and no other things change in the 7, and I'll talk about the 7th in a moment, you're probably good for 5 years, and then you can get that checked again. But again, if things change, they change. But the other thing, you know, Laura, is that the American College of Cardiology and the American Heart Association recommend what's called the atherosclerotic cardiovascular disease risk estimation. So when an individual is being covered for Life Simple 7, most of those Simple 7 and then add to that race, ethnicity, are used to calculate your lifetime risk of having a bad thing happen, a cardiovascular event, as we call them. That includes heart attacks, strokes, needing to have surgery to prevent having a heart attack or stroke. That risk estimation is done, and based on your value, even if your cholesterol is relatively normal, if you have a high risk, your doctor and you should have a conversation about the value of being on a cholesterol lowering agent, even below where you already are. The seventh thing is diabetes glucose. And that's critically important because diabetes, the leading cause of death in people with diabetes. Heart disease is the leading cause of death. It is, you might as well just say you had a heart attack if you have diabetes. It gives you the same risk profile. And there is something called pre-diabetes that we can measure with a blood test. And so the two blood tests that probably could be done, depending on risk factor profile that includes age, would be blood glucose or hemoglobin A1C, which is a different way of figuring out what one's level of glucose control is, or a lipid panel, which would be that cholesterol screen, not the heavy duty one, the preliminary one. For most people, that works. And that's a good place to start for most people. And then depending on family history, other risk factors, one might think about tests I saw in the chat, like C-reactive protein, or scans, or the small particle lipid tests.
Very good. And C-reactive protein, let's talk about that, because there's a lot of press about inflammation today and inflammation related to the heart. C-reactive protein does have its place, certainly. What do you think about getting that as a routine screen in somebody who's otherwise low to average risk? And what do you do when it's really high? I mean, the thing I struggle with is there's a lot of things besides risk for heart disease, this sort of chronic inflammation we think of, that can cause a high C-reactive protein, including a cold, an arthritic disorder. So, when do you put that in your panel?
So the American Heart Association would say that C-reactive protein has a place as a follow-on. So you've got a patient and you might be in this sort of I'm not quite sure what to do based on the ASCVD risk estimation. You have a family history that's a little bit troubling. That might be a time where a C-reactive protein makes some sense to further specify, to give you some more specificity about what is or isn't going on. The truth is, we would argue that that for most folks, if we were following that diet that we were saying would be recommended, and if you wanted to see specifics, because you can see that the American Heart Association, American College of Cardiology, and others recommend eating more fruits and vegetables, and fruits and vegetables, by the way, chock full of antioxidants. So the degree to which C-reactive protein is a reflection of inflammation and oxidation, at least within our diets, there are some things that we can do. The other is that there are specific diets that I would say, go have a look at that and see how you can do variations on those described dietary patterns that might fit. The Mediterranean diet is one that we've all heard about. I would say to you that you can't go wrong with the DASH diet. That's the dietary approach to stop hypertension. And even if you don't have hypertension, it promotes basically the things that I just said. And my new favorite diet to sort of talk about a little bit is what's called the Milpas diet, M-I-L-P-A-S. And the Milpas diet, so the Mediterranean diet is kind of based in Europe. The Milpas diet is based in the Americas. And the three kind of foundational parts of that diet are beans, talked about legumes earlier, corn, and squash. If you think about it, and you think about everything you've ever heard about the foods that were eaten by the indigenous people of the Americas, those were the indigenous foods. And if you dig a little bit deeper, you'll find that it is a plant-based diet. I've added milpas to be kind of culturally expansive in my talks about healthy eating. Milpas, Mediterranean, a DASH diet, and there's no doubt in my mind that a diet, if we were to look at the way people eat in Japan, the way people eat in Asia, there are elements of Asian cuisine that are also very much in line with what we would say is a plant-based, heart-healthy diet.
Okay, so we've had a couple questions related to either supplements or statins. And I want to first talk about supplements and then talk about statins. So are there any supplements that you think are must takes? And then the second question is whether there are any supplements, and in the particular question D3 and K2, that you actually think reverse calcification.
So I'm going to wear my AHA hat now because I don't want to be speaking just sort of off the cuff. And even my off the cuff comments have all been based on the science where I feel really, really comfortable. Some of these areas, I'll be really honest with you. I'm a family physician, and I learned early on, be confident about the things you know and be humble about the things that you don't completely know. The American Heart Association would say, for most people, eating a plant-based diet, particularly one that includes animal protein, is one where there's probably little need for supplements. That doesn't mean that there aren't some specific situations where that might not be, where it might be the case that a supplement would be important. One very clear example would be a pregnant woman needs supplementation, as best I understand everything. A woman who is breastfeeding could benefit from supplementation because it's very difficult to keep up with the demands of producing breast milk and keeping yourself healthy. So those are two situations where I would say, yeah. Again, for most folks, I will say that for people who are eating particularly a strictly vegan diet and maybe even some vegetarian diets, those are situations where conversations ought to be had with a physician, and a conversation ought to be had about what kind of testing might need to get done. Because I do think that data could and should drive supplementation as opposed to just a universal recommendation. My comments notwithstanding about women who are pregnant or breastfeeding. And then with regards to K2 and vitamin D, that's just beyond anything where I feel comfortable talking about, and would almost say, if you ask the question, you probably know more than I do. What's the science tell us? But again, in general, for most people, I'd say no, that's not necessary. And if I was trying to reverse either calcification or atherosclerosis, I would look more towards moving more towards a plant-based diet where you're going to get all the other benefits of a plant-based diet in addition to anything that's nutrient specific.
Okay, excellent. So let's talk about statins. When I went to medical school, statins didn't exist. That's like aging myself. But statins really have an incredibly important role in both the prevention and management of cardiovascular disease. And statins are things like Lipitor or Crestor. There are the yings and the yangs. Why do they work? How do they work? And there's a lot of fear out there that statins might cause problems. So I would just sort of love your perspective on the role of statins and what's the real risk.
So at a real high level, again, if we're talking about a 95% of the population, there's generally a benefit, if indicated, to have your cholesterol lowered, either based on your actual cholesterol value. Maybe it's high, and I don't want to talk numbers. Those are conversations that you really ought to have with your doc, or you have a high risk. and those risks are mediated by a number of other things. So again, those are conversations you ought to have with your doc. So what I would say to you is you ought to have the conversation with your physician about cholesterol level and the ASCVD risk estimator. That is a guideline, that is evidence-based recommendations from the American College of Cardiology and AHA. And then what that information yields should result in a conversation that you have with your doc. Statin drugs, so I'll date myself, they were the research was discovered by Brown and Goldstein, who were two clinician researchers here in Dallas. I know they have, the last time I saw them in person, I saw you, Laura Defina. So they are folks that are very much in the kind of Cooper Institute research family, and they received their Nobel Prizes for their work when I was in medical school. And suffice it to say that these statin drugs lower cholesterol. And they have a very interesting metabolism. The way it works is having identified and then hijacked a metabolic process that involves the movement of bile and that getting converted into cholesterol and the transport of cholesterols in your body. And that's as complicated as I want to get. But suffice it to say, they work. There's a number of classes or a number of, not even classes, a number of different statin drugs. They all generally work the same. I would say that the evidence thus far is that the benefits far outweigh the risk of any long-term problem. Everything in this world has a cost-benefit ratio, but I would say to you that with statin drugs, what they do to save lives, particularly in people who have a high risk of a cardiovascular event in person, and that includes people who've had a heart attack, they are wonderful medications that have drastically changed the trajectory of cardiovascular mortality in this country. There are other classes of drugs, because sometimes statin drugs are not tolerated by certain individuals. It is not the majority of people, but there are people who don't tolerate them. There are people who don't respond to them as well as they might otherwise. And those drugs, again, are more complicated classes. They cost a little bit more. The good news about statin drugs is they are available generically. They have made a huge difference in treating people with familial hypercholesterolemia. That is a genetic condition where cholesterol levels are off the charts. So I'm keeping this really high level on purpose. Statin drugs absolutely have a role to play. They are part of the toolkit to, in some cases, prevent. So that's the one thing we can talk about here is that despite all the things I've said about a few things, that cardiovascular risk estimation, cardiovascular event risk estimation does include use of statin drugs to prevent a first event. So that is using statin drugs as prophylaxis, that is for prevention. And I feel that science is pretty strong. ACC and AHA spend a lot of time and effort reviewing the science, determining the power of that science, the rigor of that science, the implications of that science before they make recommendations. And you would see those in the 2019 Primary Prevention of Cardiovascular Disease recommendations.
Excellent. And I think, that gets back to your point about having a visit with your doctor and making sure that your preventive healthcare is based on knowing your numbers and what your risks are that might lead to a doctor considering a statin, in addition to the lifestyle modifiers you've already talked about.
That's exactly right. So let's be clear that that plant-based diet or plant-heavy diet, that dietary pattern we talked about, is one that will help in managing what could be a high cholesterol situation for a particular person.
Perfect. Okay, so we have about 5 minutes left, and I am going to focus on the topic of the last 2 years, COVID and COVID cardiovascular risk. What do
Okay.
you need to know if we've had COVID? You know, to your point, we should let our doctors know so we know what comes down the pike. But what are the cardiovascular things that are being seen with COVID, and what advice can you give us?
So I'm going to start even before what we saw with COVID, because what we saw because of COVID very early on, in as early as February of 2020, it was clear based on what was going on in Wuhan, China, that underlying cardiovascular disease and high blood pressure and having had a stroke were predictors of a more severe course of COVID, including dying from it. As the pandemic spread into Europe and then into the United States, overweight and obesity also became very, very real, identifiable risk factors. Absolutely, hands down, making a difference. And I didn't mention diabetes, but diabetes is another one. So if you think about it from Life Simple 7 perspective, 4 of Life Simple 7, and then I'm going to add a 5th because we just talked about it earlier, but maybe even a 6th. 4 of Life Simple 7, having a high cholesterol, doesn't quite come out, but I would say to you that if you looked at people with underlying cardiovascular disease, of course, hypercholesterolemia plays a role, but definitely hypertension, definitely diabetes, definitely overweight and obesity. I talked a minute ago about physical inactivity seems to correlate with a worse COVID outcome, and tobacco use also was another one early on that was identified. Let's be clear, age is a risk factor, but that's not a modifiable risk factor. And why is that important? Because the other evidence that has emerged, a few early studies, are that if indeed you have high blood pressure or high cholesterol and you're taking your medications, compared to people who have diagnoses that are not, there seemed to be a less severe course of COVID-19 among those who were taking their medications for their underlying conditions. So that's one. The other thing we learned is that COVID-19 affects many parts of the body, including the heart, in all kinds of different and interesting ways. Cardiomyositis and cardiomyopathies are one of them. Some of that is transient, and particularly among young adults, and so we provided guidance as an organization to practicing clinicians around what to think about when someone was being admitted to the hospital with COVID-19. One of the other things the American Heart Association did, and you'll appreciate this, Laura, is that we created a COVID-19 cardiovascular registry. And so we were tracking patients through our other hospital-based data registry and quality improvement modules called Get With The Guidelines, and added to that, not only within those modules tracking COVID-19, but we stood up a complete separate COVID-19 registry, and have gotten tremendous insight from that. And what we don't know yet is the degree to which that transient nature from a symptom perspective of things like cardiomyopathies don't manifest later on as maybe a predisposition to develop heart failure or some other cardiovascular disease. We just don't know. And so it comes back to what I said earlier as it relates to COVID. It is so important, if there was any delay in your care, to get back with your doctor's office. If you had COVID, then please let the doctor know. Let them know now, because one of the reasons why that's so important is that our memories sometimes don't work as well as we wish they would. And so if you do it now, you're more likely to have the zone of infection and disease closer to when it really was than if you wait 3 or 4 years and in an interview somebody asks you to try to recall if you had COVID. You may remember, but you may forget the month and the circumstances. So much better, and it's important that we track that. So that was really, really high level. We knew in advance that cardiovascular disease was an underlying risk factor. Our warnings were about that. I can't state enough that this is an organization that says go get vaccinated no matter what. But if you have an underlying medical condition, please go get vaccinated so you can get the protection from the really bad COVID that you might have otherwise. Second, COVID infects the heart. Not universally, but it can have an effect. Generally, it's transient. Whatever effect it has seems to go away in most people. What we don't know is the long COVID. We know that there's some cardiovascular manifestations in some. We don't know if that's going to be only kind of in a acute / intermediate presentation, or whether there will be longer term or long range presentations that will have been contributed to by adding to a predisposition for disease with COVID. I hope that helped.
That was absolutely excellent. Well, at this point, I first want to thank our incredibly engaged audience. We've had some great questions, and we've tried to address as many as we can in the context of this last hour. I want to thank Dr. Sanchez for his dedication to helping us improve the quality and quantity of life. Excellent conversation today. I learned so much every time I talk to you. For the audience, I want to invite you to our next Coffee with Cooper, which will be Tuesday, March 29th, with Dr. Riva Rawl, who's a preventive medicine physician at the Cooper Clinic in the Platinum program. And she is going to focus on respecting the power of sleep. Again, thank you to Dr. Sanchez, and thank you for everyone in the audience for joining us today. Have a great day and get your Simple 7.
Get your vaccine and booster. See you later.
Bye.